Videos, wir werden jetzt dann live. So.
Ja. Schau ich.
Hier hinein.
Okay. Hello and welcome, ladies and gentlemen, to this webinar that we hold today on the occasion of the World Cancer Day 2022. It is my pleasure to see you all right here from Vienna and the Central European Cancer Center at the Wiener Privatklinik, which has in the meantime quite a long tradition to treat and diagnose patients with malignant diseases. Now, during the last couple of years, and we've been in existence almost 5 years now here, we have gathered extremely experienced specialists in oncology, be it in diagnostics, be it in thoracic, being in breast or colorectal cancer treatment, and also concerning surgical as well as medical oncological procedures. So I'm very happy and proud today that I'm with you, and my name is Christoph Zininski. I'm the medical director of Wiener Privatklinik, and I'm also coordinating the Central European Cancer Center here. That I'm here today with Professor Martha Hoffmann, who is a very, very well experienced, extremely well published diagnostician in nuclear medicine, and who runs the PET-CT unit that is present within the radiology center, which is present on the premises of Wiener Privatklinik, and Professor Hoda, who is professor of thoracic surgery at the General Hospital AKH in Vienna, and who is doing a series of procedures, including both diagnostic as well as therapeutic thoracic interventions by surgical means. We are here to answer your questions today, and as you all know, we do have offices in Bucharest as well as in Timișoara, and we are very, very happy if you come and see these offices of Wiener Privatklinik, both in Bucharest or in Timișoara, and we will be very glad to answer not only your questions, but also to handle your cases on a very personal way, and also enable you to come to Vienna for both diagnostics and treatment. This is always state of the art, and not only state of the art, but at the last development, and we are catering to the best methods that there are in diagnosis and treatment. And we want to discuss today, apart from a series of other malignancies which we are treating here, and these are really going across the entire spectrum of malignancies, we're here today to discuss thoracic malignancies, and particularly focusing on lung cancer. Thank you very much for sending us a series of questions, and I just want to point out here that during the last year alone, we've been treating about 100 patients from abroad with lung cancer diagnosis, and this with very high success rates, not only concerning immediate outcomes, but also on the long term, which we are following up by telemedical means, making you the journey to Vienna in times of the coronavirus disease as easy as possible, or as easy as possible to contact us by other means. So, ladies and gentlemen, you see that we're here not only very, very much devoted to the treatment and to diagnosis, but also very much devoted to staying in touch with you, either via the offices that we have in Bucharest or Timișoara, or via direct contact with us via telemedical means. So let me come now to the questions that have been sent to us, and I've tried very much to condensate them to a series of questions which cover the majority of the questions that you have asked us and you have sent us so nicely to answer. So the first question here is lung cancer or are thoracic cancers causing any symptoms? This is a very interesting question. I'm sure that Professor Hoda can answer this.
Sure, thanks so much. My name is Zahoud. I'm a thoracic surgeon, as you heard. So I see a lot of patients with lung cancer, and basically they all come, when they come in early stages, with actually a CT scan that has been done maybe during a workup for another surgery. So, for example, hip surgery. So these patients are asymptomatic, so we just find the lung cancer by surprise. These are the early stages, and if mainly lung cancer causes symptoms, then the disease is rather progressed. So, which means sometimes patients can have hemoptysis, which means bleeding when you're coughing, or they can have pain in the chest or any other areas in the body from metastatic spread. So basically, thoracic cancers can cause symptoms, but if they're asymptomatic, they're rather in an early stage.
Thank you very much. So the next question there is which we'll ask Professor Hoffman, is what is the best radiologic method to detect lung cancer, and which steps are taken thereafter? So maybe you want to answer the first question, and then we proceed with other diagnostic means like EBUS and other options that we all offer at Wiener Privatklinik, please.
So the first method usually to detect a lump or lesion in the lung would be a CT scan, so a computer tomography done either for the symptoms we already heard, or sometimes even for other reasons, and the lung cancer or a suspicious lesion in the lung is found by means of other diagnostic procedures during doing a CT scan for other reasons. And you do a CT scan of the thorax, and then you find this lesion, and if the lesion looks suspicious, you would then go on and let the patient go to see a specialist for thoracic surgery, for example. Not to do surgery immediately, but to do further diagnostic steps usually.
And where is the place of PET-CT? Where would you post that?
The place of PET-CT would be if the multidisciplinary team, for example, the thoracic surgeon and the oncologist or the pulmonologist, would say that this lesion in the lung looks suspicious, and the patient has, for example, risk factors. He's a heavy smoker, for example. Then such a lesion would be more alertful than in other patients, and then those multidisciplinary doctors would decide if you do a biopsy or if you do PET-CT, because PET-CT is not only the reason to decide if this lung lesion is malignant, but you would then also have a staging examination for these lesions. So not every lesion in the lung you see, you would do a PET-CT immediately for this. You would discuss this with the multidisciplinary team before that, because there are some other benign lesions you can detect, for example, hamartomas or granulomas, often from countries where tuberculosis is still a problem. They would find lesions, they look, resemble to lung cancer, but they aren't. So for that it is important you do not do PET-CT in all the patients, because then you would not have the possibility to provide PET-CT for the patients you need it for, because you do not have that many machines of that. So before you do PET-CT, you decide this with the referring oncologist or thoracic surgeon, and then the next step would be PET-CT.
So, ladies and gentlemen, you've heard right now, this was mentioned, the interdisciplinary team. Interdisciplinary means that you have to gather to do appropriate and well qualified oncology. You have to have an interdisciplinary team in place. This should consist of diagnostic specialists. It should consist of surgeons, of medical oncologists, of pathologists, and they should all be in place. So we not only offer this, but we do have tumor boards which convene on a weekly basis, where individual patient cases are being discussed and then decisions are being made. So maybe you could, Professor Holder, continue, and the question would be, which steps are taken thereafter once a nodule is being discovered?
Sure. So it's very important to do this in a good, timely manner. So we are very proud in the Wiener Privatklinik to offer first diagnosis to treatment decision within a week. So we are very proud about our diagnostic tools that we have, as we have a very quick diagnostic workup with the PET-CT and CT scan, but we also have semi-invasive and invasive methods like bronchoscopy, like EPAS-TBNA, which means that there is an ultrasound bronchoscope used to target those lesions that are PET positive, for example, or the lung lesions, and we can take biopsies and we'll have quickly the answer on that lesion. So histology is taken then, and after the histological workup, normally we have to see whether at which stage, together with all the other investigation, we can find the patient in. So if it's a local advanced stage, we rather do therapy before. If it's an early stage, we can offer surgery and maybe a treatment afterwards. And for those patients who are not fit for surgery, for example, and have early lesions, we can design radiation therapy in a manner that is also curative. So there is all kinds of options that we have at the Wiener Privatklinik at our cancer center. And the time is for us very important that we do this in a short time manner and that we actually communicate everything to patients and relatives clearly and also give all the options that are there. So the tumor board is essential in our institution, and in the tumor board all experts are discussing these reports and all these kind of findings for the patient's sake.
Thank you very much. So, ladies and gentlemen, as you see, we really look for lung cancer from different angles. One is an early disease, which is operable right away, where we would proceed to surgery once the primary steps of diagnosis have been taken. And very often we recommend afterwards additional treatment to maintain the good response. Or we try via medical oncological means to make a lesion which is not operable yet, to make it operable. Or we must say with certain sorrow that the disease is inoperable, and then this goes directly to systemic treatment. Now, a lot of patients have been asking whether there are benign lesions in the lung which are present there, like nodules in the lung, which are not necessarily lung cancer once you see them. So this is an important question, and maybe you could start discussing that, and again we would see how we proceed after that.
If a lesion in the lung is found and it is newly diagnosed, newly detected on CT scan, for example, the patient did not have a CT scan before, so it's the first CT scan, and on this you see a lesion in one lobe, and the lesion is clearly demarked but is so-called new, so there are more two or more possibilities. If the patient has no risk factor for lung cancer, he's non-smoking, he has not worked in a factor with, for example, inhalative agents. So the next step would be you do a control of the CT within, for example, 2 months. So if the patient is at risk having cancer, you would maybe go for fine needle biopsy, doing this by CT directed possibilities, so you can put a needle into the lesion, take out cells and investigate them by the pathologist, and then you have the answer if the tumor is malignant or not, if this is possible. If not, you may do if the lesion is larger than 8 millimeters of size, because below that the sensitivity of PET-CT is not that good. PET-CT could be an option to see if this lesion is taking up a high level of glucose. This means the lesion needs high levels of energy, because the FDG PET shows the energy intensity, energy taking up intensity of a lesion. And if it's hot on PET-CT, I think we would go for thoracic surgery to take out this lesion and see if it's the only lesion that's hot, because with the PET-CT you also have the staging of the disease. But you always need histology to say what sort of tumor this is, and to know what therapy will be given afterwards if necessary.
So that is an important point, which covers also a question that we have received, and that is that a story of a patient with an ear, nose, and throat cancer has developed a nodule in the lung, and the question came up: is this connected with the ear, nose, and throat cancer, or is it not? And the answer is very easily given. You should aspire for histology, and only histology can clarify the issue. So this can be either by surgical or minimal surgical means, or by invasive radiological means, which also are able to get some tissue out of this nodule, which is suspicious. So this is very simple, in fact. And all this is being offered here. We can offer all means of diagnostics and invasive procedures that have been discussed until now. Now, the question is, I think, which probably the audience will have to know, is how afraid do you have to be of surgery for lung cancer?
Yeah. So this is a common question, and I think we've developed quite well in the last 20 years. So we're offering in the Wiener Privatklinik a full range of minimal invasive thoracic surgery, which includes the so-called VATS, which is the video-assisted thoracic surgery. And this procedure with 1, 2 small incisions, sometimes 3 small incisions, without opening the chest, using a camera optics to look inside the chest. We can remove lesions with no rib spreading, less pain, early mobilization, and of course, early discharge of the patient. And especially with minimal invasive tools, we're able to offer the patient a quicker treatment afterwards, because you are not going to have a lot of problems after surgery. So the less problems with your lungs, less problems with the general health, so that you can earlier go to further treatment if necessary. So we offer this, and the other side that we offer in surgical means, Walter Klapetko and me mainly offering this, is basically that we can also take out tumors out of the lung which have pre-treatment. So there we use open surgery, and our open surgeries are always as well quite less invasive. So we spare muscles, we have small thoracotomies, and we have all technical tools to perform any kind of lung preservation to remain lung function. This is very important to us. So our thoracic surgery approach is a very modern one, and we can offer the full range of all kinds of treatment.
Thank you very much. So, ladies and gentlemen, I want to stress here the point, what happens afterwards. Now, as you've heard, we are having 2 kinds of lung cancers. One is what we call small cell lung cancer, and the other is non-small cell lung cancer. And the non-small cell lung cancers are again being subdivided between adenocarcinomas and or non-squamous and squamous carcinomas. Now, small cell lung cancers, in principle, once you have the histology, are being classically treated by chemotherapy, lately also under the addition of immunotherapy. Now, it is a fairy tale that non-small cell lung cancers like adenocarcinomas or squamous carcinomas do not respond to chemotherapy. They do very much so, particularly during the last couple of years. There have been a lot of advances which have made these diseases treatable. Now, I will come back to this a little later, and we can discuss that in the context of if surgery is not an issue or is not an option. Now, the question is also here, what happens after surgery once the tumor has been removed completely? And here, in the majority of cases, in fact, that is 75 to 80% of cases, we tend to advise for so-called adjuvant treatment. Adjuvant treatment means that you have undergone surgery, which has removed the tumor, but the tumor has certain characteristics defined by its size or by its spread into lymph nodes, etc., to make so-called micrometastases, which are cells which are distributed across the body, and once they start growing, they make overt metastases which generate a problem. So we advise for patients who have undergone surgery to have so-called adjuvant treatment, which consists of either chemotherapy or chemotherapy lately plus immunotherapy, or also sometimes with so-called targeted treatments, which are so-called tyrosine kinase inhibitors, particularly in the context of molecular changes, which are typically called EGFR mutations, which are mutations of a certain kind of a molecular in a molecular context, which you can really target by molecular treatment. So we do have a lot of options here which we offer and which make patients significantly healthier and to have a significantly better survival than if they would have been operated only without any additional treatment. Now, maybe you could refer to this. How sensitive are methods to detect metastatic spread by radiologic means?
Metastatic spread.
In other words, how big or how small? What is the minimum size that you can detect by radiological means?
I would prefer going for nuclear medicine means for the detection on PET-CT, because the staging you would do with PET-CT, because PET-CT added a high sensitivity to small lesions outside of the lung and helped to reduce futile surgeries in about 20% of patients that had a so-called surgical removable tumor in the lung, and but the spread of the disease was detected by staging with PET-CT, and the size is about 8 millimeters. Sometimes even smaller. If the tumor is very hot in FDG, you would also see it in 5 millimeter size, for example. And we had some patients that were referred here for surgery, and we did find, for example, a second lesion in an adrenal gland, which is also a possibility to do surgery then on both sides. You do the surgery on the adrenal gland and on the lung. But in other cases, you would, for example, have found a lesion, small lesion in one spine, in the bone, a bony lesion, just 5 millimeters in size. And with PET-CT, you are able to find those lesions. The other thing is what you should bear in mind, that the only site where the lesions would need to be larger to find them on PET-CT is the brain, because the brain does, of course, because it's very active for thinking and things like that, you need glucose in the brain, so the glucose metabolism in the brain is high anyway, so you would not detect small lesions there. So for patients who are at risk having brain metastasis, you of course have to do brain MRI also, because in brain MRI you find lesions as small as, for example, 5 millimeters or even 3 millimeters, because they have edema around sometimes, and then you find them. So it's not always a matter of size with the metastasis, but you have to go thoroughly through the whole body images. We always do this in a 4-eye manner, so we have a radiologist and me as a nuclear medicine specialist, and we go through the CT images. You also have computer tomography images with contrast media enhancement, so you have a full diagnostic CT and you have the PET, and together this is a hybrid imaging method. You can find small lesions from the base of the skull to the midst of the thigh, and there you find more or less the relevant lesions to decide if you go immediately for surgery or you go for chemotherapy or you do a surgical intervention on the lung and additionally on adrenal gland, for example, and then you do additional radiotherapy, for example.
This is quite important, the so-called oligometastatic disease. We have a very modern cancer center here, so we follow all the newest guidelines and all the newest research, which means that in oligometastatic patients, which means patients who have one metastasis site, like in the brain or in the adrenal gland, we offer modern treatment, which means a combination of chemotherapy, systemic therapy or immunotherapy plus surgery. And so we can even, in those very rare patients who have only one metastatic site, offer curative treatment.
Maybe you could add and tell us a little bit about the possibilities to also do surgery for metastatic disease? What are the limits, and where would you say has the limit been crossed, and you cannot do any surgical interventions anymore?
My pleasure. So it's important that you know that other cancers can spread to the lung. So it's basically colorectal cancer, one of the most common, renal cell cancer, and also cancers from some bones, so soft tissues. In thoracic surgery, we do a lot of pulmonary metastasectomies, which means we remove metastatic lesions in the lung. It can be done on both lungs, depending on your lung function. It can be done minimal invasive, so we can perform this by butt surgery, or sometimes we have to open the chest for that as well when we have very small lesions. There is a limit of number that we can resect, so it's always depending on your lung function. But nowadays we even have patients who have liver metastasis and lung metastasis for colorectal cancer. We can offer them potential cure in combination with chemotherapy or targeted treatment or immunotherapy. So I think there are valid methods, and it's important that a surgeon assesses together with an oncologist and with an imaging specialist that the primary time you should show up with your scan, you have to assess whether it's resectable or it's treatable. So this we do basically in the tumor board. That's why our tumor board at the VPK is very important.
Thank you very much. So one thing which is emerging here very much, ladies and gentlemen, is the reasons for lung cancer. And the reason number one for lung cancer, the highest and most likely reason to develop lung cancer is smoking. So you please should not smoke. If your children smoke, tell them to stop. If they don't stop, take your money away. You should do everything you can to influence your relatives, your immediate relatives, to stop smoking, because everything then is just reduced to a reduction of risk. Of course, you can do low dose or low intensity computerized tomography for early detection of lung cancers in smokers. You can do that. And we know that there's a famous trial, we know that this can truly make or recognize lung cancers early. That is correct. But still, it's better to not develop it at all than to continue smoking and to develop lung cancer, the course of which is very often quite unpredictable. So that is one of the important things here.
I would like to add here that, of course, if you are not able to stop smoking, or if you have stopped smoking and still want to know if you are at risk having lung cancer, there is this trial you mentioned, the National Lung Screening Trial that was done in the US, and they found that if you do low dose CT in patients older than 55, younger than 74, so those were the patients included, and they did a low dose CT in heavy smokers. That means they should have a history of 30-year packs. That means 30 years of smoking one package a day. If you smoke 2 packages a day, it goes down to 15 years, of course. So this is the relation. You have to have smoked for this, and you have to have stopped, if you have stopped smoking within 15 years or so before the test. And then you go for a low-dose CT, and if there is found a lesion in your lung that was not there before, so you go for a second low-dose CT after 1 year, but you do not go to the radiologist every year, do a CT scan and then go home again and see everything was fine. So this has always to be multidisciplinary. So you have to be able to refrain from smoking. It does not make sense you go on smoking and do a CT scan every year. So this is always including that you will refrain from smoking and you will seek help for refraining from smoking. So this multidisciplinary team also consists of psychologists who help you with refraining from smoking. Then this makes sense. It does not make sense going on smoking and doing a CT every year and you feel healthy then, because of course we all know there are other diseases that come from smoking, bladder cancer, breast cancer,
Cardiovascular
and also
diseases.
cardiovascular
COPD.
diseases, COPD. So there are lots of diseases you could also pick up by smoking. But there is, of course, an advantage in cancer-related death of 20% when you detect the cancer earlier by doing this low-dose CT when you smoke. And there are also European societies that now recommend this if you're a heavy smoker and older than 55. Also the Austrian Society of Radiology recommends that you do this low-dose CT for 2 times on a yearly basis. But you do not do it every year. You do it for 2 years, and you have to try to quit smoking in the same time span.
So, ladies and gentlemen, that is very much important, and these additions were extremely important to just remember one sentence: tobacco is your enemy, and the enemy of your family, because they are also passive smokers when you smoke, and you're doing harm to your family when you're smoking, and the others are passive smokers. So stop smoking. Very, very important. Or don't smoke at all. Now, the next question comes here, which is quite important, and which is a whole area of very, very successful research, and has been even awarded the Nobel Prize in the year 2018, is what do you do if patients cannot undergo surgery? They do have lung cancer, and this has been histologically verified. Now, this is the domain of medical oncology, meaning that these patients usually have 3 options. Either they have no response at all to molecular changes, or they do have molecular changes within the tumor. If they don't have molecular changes, the question always is, how amenable are they for immunotherapy? Immunotherapy means, in other words, that what you have there is that you do have a malignancy which is able to be influenced by the immune system or unable to be influenced by the immune system. Now, what tumors do usually is that they suppress the immune system to eliminate them. And what happens is that we do have antibodies, and these antibodies are able to alleviate the suppression. In other words, suppress the suppression, and thereby make the immune system, enable the immune system to attack the tumor. So either we have it, we either administer these antibodies, which are called immune checkpoint inhibitors, alone and without chemotherapy, in such cases where we can expect, due to certain histological investigations, that these patients will respond to immunotherapy, or we combine immunotherapy with chemotherapy, leading to a significantly better outcome than if these patients would have been treated with chemotherapy alone. Now, very often we continue immunotherapy for a very long time, and we know for the first time in very many years that due to these advances, tumor deaths have dropped in the year 2017, 2018, and 2019 by these advances that were made based upon scientific insights. Now, the other option that we have here is a phenomenon which is called molecular mutations. This means that your tumor harbors a certain change, a certain molecular change, which leads to the fact that a certain molecular compound is making the tumor grow. And we do have, in a multiplicity of tumors, we do have such targets which we can, again, treat in a targeted way, which is then called precision medicine or personalized medicine, because it refers to a very certain finding that we have. Now, these molecular changes have not only led to better treatment options, but also have shown us that there is no such thing as a lung cancer. There are very many lung cancers or cancers which are located within the lung, which fall completely apart according to the growth pattern they have based upon the molecular profile. Now, of course, we know that these patients who have certain molecular profiles progress sometimes or very often despite of treatment which is concentrating on these molecular changes. So what do we do then? What we do then is typically we do a rebiopsy. We have to do a rebiopsy whenever we see lung cancers grow, because we might be able to offer other treatment options which are targeting this new molecular change. So maybe Professor Holder, you want to say a couple of words in this context, how to proceed here surgically?
Yeah, it's quite important to have rebiopsies, as I heard, because of the molecular profile that can even change in relapsed disease. So what we do is we have the tools of bronchoscopy and EBUS-TBNA. So we have a very active bronchoscopic service where we can easily schedule a rebiopsy for you as well. We have a very good image-guided biopsy unit, which also can provide quickly access to good biopsies, which can be used for pathological workup for all kinds of mutations and changes. The other thing is that in some cases, if you had an early stage and you were operated and then you relapse, so the cancer returns back, there is always a possibility to look for either local treatment, which means if this is localized disease in the lung, maybe on the same side, we can offer another surgery, or we can combine our efforts together with the radiation oncology and radiate that site, and add as well some treatment when we have tissue biopsy, in a sense that chemo or immunotherapy can be given as well. So we have all of these options, and in our modern way that we think here in treating lung cancer, we always evaluate every option very thoroughly.
So, ladies and gentlemen, let me reiterate here. In order to provide you with best treatment in lung cancer, and that is why we have chosen to present to you all these advances that are present in this very disease, is that you have to have a team which is consisting not only of diagnostic specialists, surgeons, medical oncologists, but very importantly so, of pathologists, and pathologists who are able to deliver molecular analyses. This is a method called next generation sequencing, where a series or an abundance of genes are analyzed for the molecular mutations. And let me tell you just anecdotically that only very recently was there a drug approved for a mutation which is called KRAS mutation, where we are having a very new treatment option for roughly 30% of all patients in the lung cancer setting. So without molecular analysis, an appropriate treatment of lung cancer is frankly impossible. So we do have a couple of questions here again coming up, and one of the questions is, when do you remove the entire lung, and when do you remove only parts of the lung?
Yeah, thanks. So I think this is an important question, since removing lung tissues has always something to do with lung function, and as well as the location of the tumor, and of course your quality of life. So modern surgeons are always trying to preserve lung as much as possible. A recent Japanese study has revealed that even in tumors which are below 2 centimeters and have no lymph node invasion, a small segment, so a segment of the lung, is enough with a very good survival and also very good control of disease. So it depends on if your lymph nodes are part of the are actually involved in the cancer. Depends where your lung cancer is located, whether it's quite central or peripheral in the lung. That makes a decision whether to take more or less parenchyma. In some patients who have already involvement of lymph nodes, get pre-treatment by immunotherapy, for example, or other kinds of treatment, chemotherapy, systemic treatment, the tumor shrinks, and then maybe sometimes radiation is added as a pre-surgery treatment. And in those patients, it's quite hard to spare as much lung as possible. So therefore, the option is sometimes only to take out the whole lung. However, nowadays we try to preserve lung, and we have even technical methods to reimplant one lobe to the main bronchus, for example, so spare lung in a lung sparing surgery manner, or just to preserve as much lung needed, but also resect as much lung necessary. So this is all in our momentum, surgeons here in the WPK, and also it's always depending on how advanced the cancer is.
Thank you very much. Now, another very important thing is how fast does lung cancer grow? Now, unfortunately, lung cancer is a quickly growing disease. So this is something which also has to do with follow-up investigations, which we usually advise to happen every 6 months after surgery by radiological means, being by CT scan, or if we don't know how to interpret certain findings in the neurological field, by magnetic resonance of the brain. So that is the 6 months interval between treatments is a classic, which we usually recommend based upon the biology of the disease. Maybe you want to add something to that.
Yes, a 6 months interval is the usual interval you would use. You would, if possible, and you had a spread of the disease beforehand, of course, you would then go for PET-CT for restaging, because you would then early detect recurrence of the disease either in the lung or outside of the lung. If a cancer is growing very quickly and is very aggressive, maybe for the first controls you would go for 4 months or so to be not too late for discovering recurrence. But afterwards you start with a 6 months interval, but this not for lifetime, of course, but for some years, and then you would go out of the controls, because then you would start newly again when the patient becomes symptomatic, as I recall. You would not go for a lifetime follow-up.
Maybe I can add a little thing to this too. What we learned the last 15 years is basically to diagnose lung cancer at a very early stage. As Professor Hoffman has noted out before, that there are screenings efforts in US as well as in Europe, the Nelson study. These screening studies have shown that we can detect lung cancer, mostly adenocarcinoma, at a very early stage, very early stage, which is a small radiologic change. And sometimes we are following up these radiological changes, and if they change in size or shape, we rather opt for surgery. This is how we nowadays can detect lung cancers as pre-invasive lesions, so lesions that have not spread to anything as the nearby tissue or the lymph nodes. So it's crucial to have screening efforts. It's crucial to make the right decision in changes of size of lesions, and we are happy that we can offer you here as well the possibility of screening and the consequences of screening. So not futile surgery, but well thought of surgery and diagnostic methods that are possible to detect lung cancer at such an early stage that the survival can be over 100% in 5 years.
Thank you very much. So this is very much in context with one of the questions that's being asked. Ladies and gentlemen, there is no such thing like an overdiagnosis of cancer. If cancer is being detected, the first attempt should be made, and this very categorically so, should be made to remove the cancer as radically as possible. Radically meaning as much cancer tissue removed as possible within the healthy tissue. Now, with all the means that we heard about, this is very easily done by minimal invasive procedures that you do not have to be afraid of and which are truly life-saving. So please do not play with your lives. Ladies and gentlemen, we've come now to an end. It's 45 minutes, and that's what was supposed that we have this meeting in order to not overload you with information, because of course we know that all virtual meetings are having a certain limit of attention. But as this will be on the web page and also on the internet, you can again look at these presentations, and of course go through them as many times as you want in order to extract information that will interest you most. At any rate, ladies and gentlemen, let me assure you that we are having all the methods in place here to attract you, and one thing I want to mention, and that is that everybody who is doing medical interventions at the Central European Cancer Center at Wiener Privatklinik is a highly recognized, very well respected individual within the scientific community. That is an important thing because science drives our knowledge. And science, which drives our knowledge, is good for you because you're being guaranteed the best and most modern treatment there is in the world. Now let me add you another aspect. Even if you do not speak English, you are more than welcome here. We have translators who speak your language, who speak Romanian. We have translators who are able to guide you through the entire process and be with you through the entire time that you are spending in our hospital. Please contact our international office or our offices in Bucharest or in Timișoara in order to access all the most modern means of treatment, not only lung cancer as you heard today, but also in the identical sophistication in breast cancer, colorectal cancer, gynecological cancers or urogenital cancers, or any other kind of disease that you might have which worries you, and we will find you the optimal specialist who knows how to deal with this in the most appropriate way. Thank you very much for your attention. I want to thank the faculty very much. And I do hope that you stay healthy, and please watch out for this infectious disease that is out there, that you do not suffer from this at all. All the best. Was hören Sie gerade?
Jetzt zögert man.